Good afternoon, Ms. MacKenzie. As you're aware, you're about to be asked questions by Gregor, who's on my right. But first, can I ask you if you'll take the oath?
Yes, I will.
If you just remain seated, raise your right hand, and repeat these words after me. Swear by Almighty God.
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
and
nothing but the truth.
Thank
you very much, Ms. MacKenzie. Could I just say that we have quite a lot of electronic equipment in front of us, some of which is designed to amplify voice. I, for one, am hard of hearing, so I always appreciate if a witness is prepared maybe to speak a little loud, just
Okay.
a little louder than you might otherwise. And I think there may be benefit in using the directional microphone. I'm sure everyone else can hear perfectly. I'm just thinking about myself.
Okay.
Right. Mr. McGregor.
You are Miss Janice MacKenzie, is that right?
That's correct.
And you've provided a witness statement to the inquiry?
Did, yes.
Yes, which is dated the 20th of April 2022. And for the benefit of core participants, it's in bundle 6 at pages 4 to 14 of that bundle. The content of the statement is going to form part of your evidence to the inquiry, and I'm also going to ask you some questions today. If at any point you want to refer to your statement, please do let me know. And equally, if at any point you take a break, please do just say so.
Thank you.
If I could begin by covering your qualifications and experience. You qualified as a nurse in 1981, is that correct?
That's correct, yes.
And you retired in 2019?
I did, yes.
If we could just go back to the start of your career, am I right in thinking that you completed children's nursing training, qualifying as a registered children's nurse in 1983?
In 1982.
1982. Can you just explain to the inquiry, what does a registered children's nurse do?
So that I initially trained as an adult general nurse, and then I did what we called a post-registration qualification for a year to allow me then to care for children and young people.
And where did you work?
When I qualified as a children's nurse, I went down to London and worked at Great Ormond Street Children's Hospital.
And how long did you work there for?
I was there for 15 years in a variety of different roles.
And eventually, within that role, did you become a senior nurse?
I did, yes.
And there came a point where you moved back to the Royal Hospital for Sick Children in Edinburgh?
I did, yes, in 1990.
In 1998. And in 2005, were you appointed Chief Nurse for Acute Community Children's Services?
I was, yes, in Edinburgh, and that covered the Children's Service in St John's Hospital in Livingston as well.
And what did that role involve?
So that role involved, I managed the nursing provision for those services. I was also part of the Children's Services clinical management team, and that team had operational responsibility for all of Children's Services.
And at paragraph 3 of your statement, you say that a key element of my role was to ensure that patients and families receive patient-centred, safe and effective care.
That's correct, yes.
What do you mean by patient-centred, safe and effective care?
That was basically ensuring that the care that the patients were receiving was being delivered correctly, and we undertook that in a variety of different ways. We would audit the care that was being provided to the children and young people, and we would also seek feedback from families as well as dealing with any complaints or positive feedback that we received.
So as part of your role as Chief Nurse, safety was one of the parts of your role?
It was, yes, along with the medical director.
So how would your role as Chief Nurse sit with that of the medical director? How did the relationship work?
So we worked very closely together. We would both deal with any complaints that there were in relation to any clinical aspects of care, also any clinical audits that were being undertaken.
And were you involved in any form of clinical governance?
Yes, I was, yes. Myself and the medical director took the lead for that for Children's Services.
So what do you mean by clinical governance?
So clinical governance basically encompasses a number of factors. So it's in relation to any audits that we carry out, also monitoring of hospital-acquired infections, also just the actual care being delivered, reviewing any incidents that had happened, looking at any clinical risks and any change in practice that may be required as a result of that.
Thank you. I want to ask you about the proposed re-provision of the Royal Hospital for Sick Children. And at this stage, the inquiry is interested really in the preliminary stages up until the procurement exercise for the new hospital was carried out. You were involved in the project from 2006 onwards, is that correct?
That's correct, initially in my chief nurse role, yes.
So if we can focus initially on the period from 2006 to 2011, what was the nature of your involvement with the project?
So at that point, really, there was two elements to my involvement. One was leading on the patient focus and public involvement, so ensuring that there was effective consultation with children, young people and their families and relevant charities that were involved in the hospital, and also in providing clinical input to the project team about early discussions about design of the hospital, what might be required, and working with my own senior nursing team to look at those elements.
Now, within paragraph 5 of your statement, you introduce a number of groups. You see that you refer to there being a G1 core project team. What was that?
So that at that point, I wasn't. The core project team were the people that comprised directly worked in the project team. So that would have been the project director, the lead medical person. I wasn't directly involved in that group.
There was a core group.
Yes.
And although you were involved in the project, you weren't part of the
No.
core group itself.
So that group would also include the project managers.
And then you refer to a group called Clinical Redesign. What was that?
So that really was looking at how we were going to deliver the services in the new hospital. So kind of what changes we would need to make in relation to patient pathways, and generally how we were going to deliver care differently, because obviously moving into a new building, we didn't want to just move what was currently in the hospital. We wanted to be more efficient in our patient pathways.
So were you involved in the Clinical Redesign group?
I was certainly involved in aspects of it, yes.
And who else would have been involved in?
So all of the clinical teams were involved in that. So we would look at the patient pathways for patients being admitted with medical conditions, surgical conditions, and that would look at from the minute the patient was referred to the hospital, so be that from their outpatient journey, then to being admitted and then to discharge. We looked at accident emergency pathways, so there was a variety of different pathways that were explored.
And then you refer to steering group design and construction. What was that?
So that group was basically looking at what the design of the hospital was going to be, and obviously the type of construction. I wasn't directly involved in that group at that time.
Did you have any discussions with that group?
Sorry?
Did you have any discussions with that group?
I would have had, yes.
But again, feeding into it rather than being part of it?
Yes.
You then refer to a group called Workforce. What do you mean by that?
So that was a group that was looking at the workforce that would be required within the new hospital, and whether or not the workforce would need to change, both from a skill mix point of view and whether or not there was additional workforce that would be required.
And then you refer to the Children and Young People's Advisory Board. Can you explain what was the Children and Young People's Advisory?
So the Children and Young People's Advisory Board was formed to ensure that we had effective consultation and engagement with patients and their families, also any charity and organisations in relation to the new hospital. And I co-chaired that group with a parent member from the family council.
And what was the real driving force behind that group?
So it was to ensure that patients and their families had a voice in the new hospital, and that we were aware of things that were important to them, and that we met those needs.
And at a practical level, how did the group go about its task?
So the group itself met monthly. It had representatives, obviously it had parent representation, we had staff on it, and we had charity representatives on it. We undertook a wide variety of different consultation events, from kind of questionnaires to going around just talking to children and young people on the wards. We also, at that time, the existing hospital had street fairs once or twice a year, and we would just go and talk to people. We tried to be as innovative as possible in how we sought views, particularly of younger children, and we did a lot of that through using art, and we got kind of specialists in to do that.
If I can ask you to have in front of you, within bundle 4, page 9, there's a document called Record of Involvement, dated January 2011. Do you see that?
Yes, I do.
Have you seen this document before?
I have, yes.
And can you just explain what is this document?
So this document basically recorded all of the consultation and engagement that was undertaken up until 2011, and that was to so that we ourselves as a project had a record of that, but it was also for the Scottish Health Council, who had been formed by the Scottish Government to ensure that there was effective consultation and engagement in relation to any new project.
We just do examples. If we look, for example, 4 entries down, there's a date of December 2006.
Yep.
And it says to consider how will involve parents of children with complex healthcare needs. Do you see that?
Yes.
It says meeting with Anne Wilson, contact a family. You were mentioned together with Rose Byrne. Just as an example, what would that entry be recording?
So that would be recording that we met with Contact a Family, which is a charity that specifically supports families with complex needs, and we would have discussed at that meeting how best to elicit the views of those families. And that then resulted in an agreement that we would ask parents to complete a questionnaire.
Within the bundle, still within the record of involvement, if we looked at to page 13, please. And you see that the second last entry there, which is for the 21st of November 2009, the entry says inform of progress of project and share concept design. Do you see that?
Yes.
So is that really a recording, a discussion that's taking place in relation to the concept design for the new hospital?
So that basically was recording that we were providing feedback to more of the kind of general public. So that was happening at a Christmas fair that was happening at the hospital, and the general public would come to that, as well as families. So it was a poster display, and members of the project team would be there to answer any questions that people had.
And then if we move through them, page 15, the third last entry, there's a series of dates, including the 27th March 2010 through to the 26th of June 2010, and we see that recording to seek the views of the young people group on the 1 to 200 design. See that? What was that?
So that basically, we formed a young people's advisory group in 2007, because whilst we had the family council, which had parent representatives, we didn't have a group specifically for young people. So that would have involved the project team and the then architects at that time going along to the young people's group and showing them the designs at that point at the 1 to 200 level, so that they got their input and feedback into whether or not, from a young person's perspective, the design was meeting their needs.
So whenever we see, really, for all the follows, we see re-provision team, Nightingales, then the next entry, re-provision team, and BAM. What are those entries?
So again, those entries are recording that there was feedback and consultation with relevant groups, with the project team and the architects.
So effectively, input from children's and young group being conveyed directly to the design team.
Yes, and because obviously prior to that stage in the design, the young people had already given their views about things that were important to them. So it was to see, had the design actually taken account of those issues. So I suppose, as way of an example, the young people had said to us previously that the current playrooms that we had in the old hospital were very focused on young children, and they wanted facilities that were more young people friendly. So in the new hospital we had planned for specific recreational areas for the young people. So that was so they would input into that.
And if we could just look at the final entry on page 15, this is again consulting on concept design. There's an entry that says re-provision team and HFS. What's the reference to HFS?
So that would have been Health Facilities Scotland. Go back to what it said. Thanks. So that would have involved, from my memory, looking at the concept design and HFS being involved in that, but I don't recall directly myself being involved in that, so I'm not sure what they discussed.
You've mentioned a body called Health Facilities Scotland. What's Health Facilities Scotland?
So Health Facilities Scotland is a Scottish Government body that looks at more of the facilities side of buildings, etc. Again, I wasn't directly involved in it.
So from 2011 onwards, you tell us in your statement that you were asked to join the project team. Is that right?
That's correct, yes.
Okay. Who asked you to join the project team?
So I was asked by Brian Curry, who was the new project director at that point, because the previous project director had left, as had the clinical lead, so that he had recognised that there was a gap in the project and there needed to be some more direct clinical involvement. So I was asked to join initially on a kind of part-time basis. So I spent 50% of my time working with the project, and 50% of my time I carried on with my chief nurse role.
So you've mentioned the project team, and you've mentioned yourself, and you've mentioned Brian Curry. Who else formed the project team?
There would have, at that time, there was several project managers and administrative support. And as the project progressed, then the project team had additional members joined.
But approximately how many people would be on the project team?
In 2011, there would have probably been about 7 or 8 people.
And as the project went on, did that number increase or decrease?
It increased.
And in relation to the project team, who was the project team effectively reporting in?
So the project team reported to the project sponsor and ultimately to the NHS Lothian Health Board.
No, what do you mean by the term project sponsor?
So that was the executive director who had responsibility for the project overall, and was the link with the executive team at the health board.
And who was that?
At that time, it was Jackie Sainsbury.
So if I can just make sure I'm understanding effectively the chain here in terms of governance, you'd have the actual health board itself at the top, then you'd have the project sponsor, sits on the board but is effectively a link between the board and the project team.
Yes, and we also had a project board as well that the project sponsor chaired, and that had people from the project team on it, as well as representatives from the Children's Services Management team and other key individuals.
So you had the project team, but you also had a project board as well. And did you sit on the project board?
Not initially at that time, but when I became full-time on the project, yes, I did.
So in 2011, you were part of the project team, but not part of the project board, is that right?
Not that I can recall.
So just again, trying to think about people in the project team, who was on the project board as you understood it at this time?
So obviously the project sponsor chaired it, the project director was on it. Some of the project managers would attend at times. I certainly did attend the project board at times if there was key issues to be discussed. The director of operations and the medical director from Children's Services were on that. The head of estates, I'm sure, was on the group. Infection control were represented. They probably were the key people. There were somebody from the Scottish Government, and there were some other people, but I can't call.
And in terms of the project team, can you just explain to the inquiry how that worked? Did people work individually? Did you work collectively? Were things
No, we worked very very collaboratively, partly to ensure that everybody in the team knew what was happening, so anybody could kind of pick up any issues. Obviously, people had pieces of work that they were leading on, but we had weekly team meetings to ensure that everybody knew what was happening. We worked in an open plan office, so it was very easy to kind of know what was happening, and we often supported each other. So when there would be meetings with clinical teams, etc., there was always at least 2 people from the project team attended those, so that there was always somebody there to kind of answer any queries if the other person was off.
So just so I make sure I'm understanding this, there's the formal meetings that you said were approximately fortnightly, is that right?
So the project team had weekly meetings. With the whole project team there, and the project board met monthly.
But in addition to that, you also mentioned there was a lot of informal communication.
There was a lot of informal communication, yes.
And can you just talk us through what was exactly your role within the project team at this time, 2011 onward?
So my role was to ensure that there was effective clinical input into the project, and to ensure that from a design perspective it met the clinical requirements. I was the key link with the clinical teams, and any professional teams as well. And I provided advice to the project team, to the architects, and anybody really else that asked for my advice.
Were there any other clinicians in the project team at this time?
So several of the project managers had a clinical background, so they were on, so they were obviously had a clinical background. And because I had worked in children's services, I obviously know the clinical teams very well, so I would regularly meet with the clinical teams.
If we could return then, so I can ask you some questions about the Children and Young People's Advisory Board. I think you mentioned that you co-chaired that group, is that right?
Yes.
And it met, you say in your statement, from 2006 until approximately 2009.
Yes.
What was it seeking to do? What was the Children and Young People's Advisory Board seeking?
So it was seeking to ensure that we were consulting and engaging with children and young people and their families, and that any information that we received was being fed back into the project.
And you'd mentioned that a questionnaire was sent out to patients and families. If I could ask you to look within Bundle 4 at document 3 on page 17.
Yes.
Is this the questionnaire that you're talking about?
And yes, that was one of the questionnaires that we sent out, yes.
And if we look at the types of questions that were being issued, for example, question 6, there's a question, all single ensuite rooms. Do you see that?
Yes.
Why were you asking that question?
So we were aware at the time that the Scottish Government was looking at whether or not new builds should be 100% single rooms. So the project team had asked us to include a question to children, young people and families about what their views were about single rooms, or whether or not we should have a combination of single rooms and bedded bays. And so that's why we included it.
And we also see at question 7, asked combination of single ensuite rooms and 4/6 bedded bays.
Yes.
Was that obviously linked in with question 6
Yes.
in terms of the rationale? What responses did you give to that questionnaire?
So the questionnaire went out to a number of different groups. Obviously, it went out in general terms to children and young people and their families, but we also sent it out through Contact a Family that I spoke about earlier. We also sent it out to through the hospital and outreach teaching service because the children and young people that they support tend to be very difficult to reach, so that was a good way to do that. So the overall, in relation to the question about single rooms or whether or not a combination of single rooms and bedded bays, was that there was support for there being a combination. And
approximately what was the level of support?
So it did vary in different groups. Certainly the hospital and outreach teaching service, which is primarily it's primarily teenagers and also children and young people who were utilising the child and adolescent mental health service. So they were more in favour of single rooms, which we fully expected would happen. And in the new build, we certainly took account of that. But the rest were about kind of 70–80% were in favour of a mixture.
We're talking about in terms of young children?
Young, yes, younger, the kind of under teenagers, yeah.
Multi-bed wards. Were clinical staff consulted on similar issues?
Yes, they were. So the project team led on getting clinical staff's views on what the bed configuration should be.
And what views did clinical staff express on this issue? So
the clinical staff were not supportive of having 100% single rooms for a variety of reasons. Certainly around patient safety, the ability to observe children, particularly young children. There was also concern about the isolation factor for young children of being in a single room and the impact that would have on their development, particularly if they were in hospital for a prolonged period of time. Also, not all children do have their parent being resident with them, and we know that young children in a single room, that is very difficult for them. Also, just from a purely practical point of view, young children are not able to seek the attention of a nurse. They can't use a nurse call button. Also, children do tend to clinically deteriorate much more quickly than adults do. So there was a real concern that if all of the children were in single rooms, the observation of them would be very difficult.
In terms of the views that you've expressed in your statement, particularly at paragraphs 9 and paragraphs 21, would you agree that really the justifications for not having 100% single rooms really boil down to issues of, firstly, safety for children, and then secondly, children having a feeling of isolation?
Yes.
And was that view shared by the Young People's Advisory Group?
It was, yes, it was. They had visited several hospitals. We had facilitated that, several new build hospitals, and they felt strongly that there should be a mixture. And they wanted the option themselves of whether or not they wanted to be in a single room or in a mixed, in a 4-bedded bay.
If I could ask you to look at a document, please, in bundle 4, document 4 at page 19, please. Is this a document headed up feedback on single room accommodation? Yeah.
Yes.
And is it completed by a Gary Buchanan?
That's right, yes.
And he's described as interim co-chair. Was he co-chairing this group with you?
No, he was co-chairing it with one of the project managers from the project team.
We see Mr. Buchanan states, firstly, we felt it necessary to have a combination of single rooms and bedded bays. We understand that in terms of hygiene, single rooms are easier to clean and maintain. However, we feel that for babies and toddlers, individual rooms are not going to work. This is because babies and toddlers need to be watched constantly, and this would be difficult if they were in individual rooms as opposed to bedded bays with nurses' stations. Also, it could be detrimental socially as they like someone to play with. Aberdeen's Children's Hospital has a nice layout of bedded bays as they are bright and lots of room to do. Do you see that?
Yes.
Did that effectively reflect not just the views of the Young People's Advisory Group, but also your own views?
Yes.
If I could ask you within the same bundle 4 to look on to the next page, please, to page 20. You see there's a document called Single Room Provision in Scotland Draft Nursing Report of March 2007.
Yes.
Have you seen that report before?
I have, yes.
Can you just explain to the inquiry, what was this draft nursing report?
So this was a report that was produced by the Scottish Government through the Nurse Directors Group. So that group had all of the board nurse directors from every board in Scotland on it. And they were looking at, obviously, the single room provision. NHS Lothian's nurse director was on that group, and she was aware that we had undertaken consultation in relation to single rooms. So we were asked to give our response to that.
And if we look to page 22 of the bundle, please. Third paragraph on that page. See that it states the use of a building impacts on not only infection prevention and control, but has also been linked to patient dignity, confidentiality, reduction of errors, positive staff satisfaction and patient satisfaction.
Yes.
And would you agree with those views in terms of there's other issues in addition to infection prevention and control that need to be considered in relation to a hospital?
I would, yes.
We then, within the same document, looked at page 25, the bundle. There's the heading Children's Services.
Yes.
It's, as part of the re-provision project to replace the Royal Hospital for Sick Children in Edinburgh, a number of consultation initiatives took place with small groups from charity and volunteering organisations. One of the questions that was asked was, should the patient areas have single rooms or 4/6 beds or a mixture of both? Responses indicated a mixed view depending on the organisation approached. However, children, young people and their families preferred an option that included but was not exclusively single rooms. The majority of the respondents preferring a mixed room approach. And is that effectively the response summarised from the survey that we've looked at?
Yes.
It continues, currently children and young people are allocated single rooms prioritised the following criteria: protection, relation, mothers who breastfeed, primarily adolescents. And it continues, views of children's nurses. Not all parents will stay with their child overnight or are visiting the hospital all the time during the day. Children and many young people often feel very isolated and alone when they're in cubicles, enjoy the social interaction in the ward area. Children. In addition, younger children and babies, unlike adults, are not able to use all systems, and therefore observational or difficult all or to be nursed in single rooms. Children, as part of their development, require social interaction for those who are unable to move down to their beds, and therefore not able to use the room, benefit from being beside other children. Again, is that really a summary of the views that you'd received from clinical staff in terms of the discussions that took place in the Edinburgh project?
Yes, it is.
I want to now ask you some questions about government policy on single bed rooms, particularly in the period from 2006 to 2010. Before we go on and look at the documents, what was your general understanding of Scottish Government policy in that period on single bedrooms for?
So I obviously was aware of the three guidance that the Scottish Government issued. The first one in 2006 stating that there should be an arrangement of 50%, 75 or 100% single occupancy room, and then that view changed in the other two documents where it said that there should be 100% provision of single rooms unless there was a clinical reason to deviate from.
So if we could perhaps just look firstly at the interim guidance from 2006, so that's in Bundle 3, Volume 1, Document 5 at page 152. See a document headed Interim Guidance.
Thank you.
For NHS Scotland provision of single room accommodation.
Yes.
And if we just perhaps read short the first paragraph, it says enabling beds to be provided in an arrangement of 50%, 75% or 100% single occupancy rooms. Is that what you were referring to earlier?
Yes.
Further down in the last full paragraph, page 152, it states in making any decision on the appropriate level of single room provision, should be fully aware of the changing perceptions described above, including the recommendations contained in the EU HPN report. Do you know what the EU HPN report is?
No, I don't.
Continues in planning for the construction or major refurbishment of healthcare facilities. It's appropriate to provide an overall single occupancy room level of between 50% and 100%. The appropriate level within that range is a matter for each individual NHS board to consider. See that?
Yes.
So at this point, perhaps moving towards 100%, but there's got to be at least between 50 and 100. And just complete that document, if we look on to page 153, we see that that was issued on the 15th of December 2006. We can then go to Bundle 4, please, and to page 60. That a document headed up recommendations from the steering group report on single room provision. Yeah. Have you seen this document before?
Yes, I have. Yeah.
What's this document?
So this document is providing, it says the recommendations from the steering group about the single room provision and the kind of background to it and the rationale for the decision that or for the recommendations that they were providing in relation to proportion of single rooms.
If we see just below paragraph 4, where it states new build facilities, the first bullet point, all new build hospitals or other healthcare facilities which will provide inpatient accommodation, there must be a presumption that all patients will be accommodated in single rooms unless there are clinical reasons bedded rooms available. See that?
Yes.
So shift in policy now, it's a presumption 100% single rooms unless there's a clinical justification otherwise.
Yes.
And if I could then ask you to look within bundle 4, document 1 on page 5. Is that a document in the top right hand corner that's got cell 48, open brackets 2008, dated the 11th of November 2008?
Yes.
And it's issued by the Scottish Government and states provision of single room accommodation and bed spacing. Then below the bold paragraph on action, it says NHS board should implement the new guidance in all schemes in excess of delegated limits that have not yet submitted outline business cases. For schemes within delegated limits, guidance should be applied for such projects that have not commenced procurement. The guidance is as follows. Then on new build facilities, for all new build hospitals or other healthcare facilities provide inpatient accommodation, there should be a presumption that all patients will be accommodated in single rooms unless there are clinical reasons bedded rooms available. You see that?
I do.
So in 2008, when you were involved in the project, was that your understanding of Scottish Government policy?
It was, yes.
My fault, Mr. McGregor. The bundle reference.
So it's bundle 4, document 1 on page 5.
Page 5. Thank you.
And just to complete the Scottish Government guidance, if I could ask you still within bundle 4 to look to document 10, please, on page 144. Again, is this a document issued by the Scottish Government, top right hand corner, cell 27, 2010, dated the 20th of July 2010?
Yes.
Bundle 4, document 10 at page 100. Paragraph 1, it firstly makes reference to the Chief Executive letter, the cell 48 that we've just looked at. And then at paragraph 3, it states that process has now been completed and a number of conclusions reaching current provision of single room accommodation is not sufficient across NHS Scotland, and 100% single room provision is clinically appropriate in most clinical settings. Then at paragraph 5, accordingly, the Chief Medical Officer concluded that the guidance set out in the above cell that there should be a presumption of 100% single rooms in future hospital developments confirmed as the policy for NHS Scotland, except for existing accommodation is the first bullet point, and then the second bullet point in new developments where there are clinical reasons for not making 100% single room provision. They should be clearly identified, articulated in the appropriate business case. However, each case would be subject to Scottish Government as part of the business case approval process. You see that?
Yes.
So was that your understanding of the position as at 20th July 2010 when you were working on the Edinburgh project?
Yes.
A presumption of 100% single beds in a new hospital unless there's a clinical justification for it.
Yes.
Lord Bury, I'm conscious that that's just after 1 o'clock. I don't anticipate being much longer, but I think I would be more than 10 to 15 minutes, so that may be an opportune point to break.
Ms. MacKenzie, can you come back this afternoon?
Yes, that's fine.
You've heard what Mr. McGregor has to say. It may not be for a very long session, but we'll take our lunch break and sit again at 2 o'clock. you
Yes.
could be back for them, that'd be great. Thank you. Bring in Ms. MacKenzie. Good afternoon, Ms. MacKenzie. I think we're ready to resume. Ms. McGregor.
Thank you, Lord. Ms. MacKenzie, before lunch we were looking at Scottish Government policies on 100% single bed rooms in hospitals unless there's a clinical justification for a departure. In relation to the Royal Hospital for Children and Young People, did you consider that there was a clinical justification for a departure from 100% single bedrooms?
Yes, I did, as did the clinical teams.
And is that for all the reasons that you've set out in your statement that we covered before lunch?
It is, yes.
And was that recorded within the business cases for the project?
It was, yes. So the report that I wrote following the consultation was an appendix in the business case.
So if we could perhaps just look at the original outline business case from 2008, that begins in Bundle 3, Volume 1 at page 272. You'll just see there's the outline business case. But if we could look on to page 321 within the bundle, please. At page 321, do we see a range of areas set out, including single rooms, beds in 2-bedded bays, and beds in 4-bedded bays?
Yes.
So, for example, in the grey shading, we'll see that for critical care, there was always going to, in terms of this business case, be both 2- and 4-bedded bays.
Yes, at that time, yes.
And if we could then look on to page 426, please. We see an appendix. Future Service Provision 6.3 Single Room Accommodation Report. Do you see that?
Yes.
Have you seen that before?
I have, yes.
What is this?
So this basically is the report that was produced following the consultation that we undertook with the families and the children, and also the clinical viewpoint.
So that's Bundle 3, Volume 1, at page 426.
Thank you.
And we see that begins with the introduction. This paper will provide information on the issue of single rooms and bed bays within the proposed new Children and Young People's Hospital in Edinburgh. A recent draft report, Single Room Provision in Scotland, produced by NHS Scotland on behalf of the Scottish Executive Nurse Directors Group, March 2007.
Thanks.
Proposes that all new hospital bills should provide a 100% single room accommodation. This recommendation was made following consultation with patients and nursing staff. However, this does not appear to have specifically involved consultation with children, young people and their families, and the nursing staff caring for this patient group. And is that the report that we've already seen earlier today?
It is, yes.
And it then goes on to outline the consultation that had taken place. And if we look onto page 427, just above clinical staff feedback, the report stating, overall, from the feedback we've received to date, it is being proposed that there will be a minimum of 50% single room accommodation for patients. However, it is important to note that the single room accommodation requires to have ensuite facilities. There should also have sufficient space for one parent to sleep overnight with the child/young person. See that? And then the final paragraph on that page, not all parents will stay with their child overnight. or are here all the time during the day. Children and many young people often feel very isolated, alone. They're in cubicles and enjoy the social interaction of being in a warded area beside other children. In addition, younger children and babies, unlike adults, are not able to use nurse call systems, and therefore observation of them is more difficult if all were to be nursed in single rooms. Children, as part of their development, require social interaction. For those who are unable to mobilise and are confined to their bed and therefore not able to use the playroom, benefit from being nursed beside other children. This is a particular issue for children who are in a hospital for a very long time. 100% single rooms would compromise the management of groups of babies and young children with the same infection, bronchiolitis. At a recent meeting of senior nurses across the UK, there was discussion about whether there should be 100% cubicles. This was not supported, as it is recognised that children find great comfort from sharing with others, especially when their parents are not with them. It was recognised that many adolescents wish to be in a single room for privacy. However, equally, many of them also wanted to share. That consideration needs to be given in relation to segregation of male and female patients. In addition, it was felt that having a 100% single rooms would require higher patient-nurse staffing ratios because of the dependence of babies and young children on nursing staff, which is different to the dependence and support required by adult patients. See that?
Yes.
So is that essentially the justification in clinical sense for a departure from 100% single?
It was, yes.
Thank you. If I can ask you then to look within bundle 4, please, to page 167 and 168. If we could begin at page 168, is that an email from you to Fiona Halcrow dated the 25th of October 2011?
Yes, it is.
Who is Fiona Halcrow and what was her role in the project?
So Fiona Halcrow was one of the project managers. She was the project manager for the Department of Clinical Neurosciences, and she has a nursing background.
And we see within that email, you say, "Hi Fiona, this paper was written in September 2007. Just to be clear, what paper are you referring to there?
The paper that was the appendix that we've just looked at to the business case.
Thank you. Whilst it's 4 years old, the views expressed by staff at that time overall have not changed. We've not done further consultation with children, young people, families on this issue. I think the paper is still relevant, as we would still want the ability to cohort patient groups. I would suggest that the date the paper was written is acknowledged, and if necessary, we can say that the clinical staff feedback remains the same." Do you see that?
Yes.
So did that represent your views as at 2011?
Did, yes.
Effectively, in terms of clinical justifications, nothing had changed?
Yes, and I had discussed that with the clinical teams and they were in agreement.
If we can look on still within bundle 4, please, but to page 180. So bundle 4, page 180. Is that a document headed up rationale for proportion of single rooms within children's wards in new build?
It is, yes.
Just explain, what is this paper?
So this is a paper that we were asked as part of the Scottish Futures Trust, who were reviewing projects. We were asked to provide the justification why we were not going with 100% single rooms.
We see, for example, in the second full paragraph, there's an acknowledgement of cell 48 and cell 27, which we saw before lunch. There's then a table with various beds. And then at the bottom of the page, just before the 2 bullet points, there are a number of reasons for not having 100% single rooms within the children's inpatient wards for the new build, which are as detailed below. And then there's a range of justifications included. You see that?
I do.
And I won't read them all out, but are they essentially the same justifications that we've already seen within the original outline business case?
Yes, they are.
And we see that's completed by you, Janice MacKenzie, in January 2012.
Yes.
What was the purpose of this being updated in 2012?
Because a new business case was to be submitted in 2012 to include the Department of Clinical Neurosciences. So the previous assumptions that had been made in the 2008 outline business case, we were re-looking at them.
And as you say, in your view, clinically nothing had changed in terms of the justifications?
Yes, in the view of the clinical teams, nothing had changed.
That obviously deals with the Royal Hospital for Children and Young People. What about the Department of Clinical Neuroscience? Was that to have 100% single beds?
That was to have 100% single bedrooms, and that was how it was planned. However, the clinical teams within the Department of Clinical Neurosciences had concerns about that from the point of view of their most critically ill patients. So they looked at the reasons for that, and a paper was written to propose that they had 2 4-bedded bays, and that was led by Fiona Halcrow, the project manager, and James Steers, who was the clinical lead.
So you're obviously aware of that, but were you involved in that aspect with the Department of Clinical Neuroscience?
I wasn't involved in the discussions with the clinical teams, say that was led by the 2 individuals that I said, but I was asked to review the paper before it was submitted.
And just so that we're clear on the paper we're talking about, if we can look at bundle 4, please, at page 182. Is that the derogation paper that we're...
Yes.
In relation to support from the Chief Medical Officer, are you aware of whether the Chief Medical Officer supported the recommendations in relation to departing from 100% single bedrooms?
Yes, I was aware that he had supported it.
But were you involved directly in those discussions?
No, I wasn't.
In relation to the design of each ward, thinking particularly about the Royal Hospital for Children and Young People, were you involved in discussions in relation to single bedrooms and multi-bed wards, and specifically where they should go within the hospital?
I was, yes.
What was the nature of the discussions that you had?
So the nature of the discussions were based on the clinical specialty for each of the ward areas, the types of conditions that were within them, the age range of the patients and their clinical needs.
And who did you discuss this with?
So they were discussed with each of the clinical teams for each of the ward areas. So that would be the medical staff, the nursing staff, the allied health professionals.
And how were those views conveyed to the design team?
They were conveyed in that we gave them a detailed breakdown of each ward, the number of beds, the number of single rooms. There were to be the number of isolation rooms and the number of 4-bedded bays.
And after that information had been conveyed, did you have any direct discussions with the design team?
I would have been involved in discussions with the architects around how the wards were going to be laid out, from the point of view of kind of the actual, whilst we had decided on the number of single rooms and 4-bedded bays, but in what configuration would they be in, and what support accommodation would be around them.
But to be clear, in terms of the design team, your discussions are with the architects only? I just want to ask you a few questions about technical requirements for the new hospital. At any point during your involvement in the project, did you discuss a ventilation strategy?
No, not directly.
Did you ever discuss it indirectly?
Not as such, and I mean, I was obviously aware that there were SHTMs, and we were on occasions asked by technical advisors for clarification around the type of patient that might be within a ward area. And that was obviously to do with many of the technical aspects.
Or were those discussions of a general nature?
Yes, so they would be about, you know, are the patients in this area, do they have, you know, are they oncology patients, that type of thing.
Thank you, Ms MacKenzie. I don't have any further questions, but His Lordship or there might be other applications.
Again, does anything arise from Ms MacKenzie's evidence that anyone wishes to take forward? Again, I'll take that as a no, Ms MacKenzie. That means that's the end of your evidence, and thank you very much for coming and providing it. We're now free to go. Thank you. Now, Ms McGregor, that's your witnesses for today, am I right?
No, my lord, there's also Mr. Edward McLaughlan.
Of course. Ms McLaughlan. Yep. Right. We'll probably take no more than 5 minutes, but it might be just a little bit more than 5 minutes, so we'll rise.